So today I'm going to be talking about stroke and why it is more than just thrombectomy, although it is, as many of you know, very much a lot of thrombectomy. So these are my disclosures. As Dr. Kim mentioned, a little bit about me. For those of you I have not yet met yet, my name is Stephanie Chen, did my residency at UM. Where I did my first infolded endovascular year. And now I've been lucky enough to go from one very beautiful beach to another all the way on the opposite side of the country. And very excited to be doing my second year of endovascular fellowship here. So I'm going to outline my talk actually based on some of the amazing mentors that I've had the privilege of training with in Miami, and some of the core values and principles I've learned from them and how it has really applied to my journey in stroke research. So the first person is Dr. Roberto Heros. He is the Papa of neurosurgery at UM. And every morning at 7 a.m. sharp, we had to be at teaching conference with Dr. Heros because he always felt that even more important than all the technical aspects of surgery was judgment. And therefore, we couldn't discuss a topic without first knowing the history, the clinical evidence behind the disease and its treatment. So I'll start by briefly going over a little background in stroke and stroke treatment. The second person, as you guys already mentioned this morning, Dr. Jacques Morcos. He is a prolific master surgeon who's taught me innumerable things, and he really became a master surgeon by being incredibly observant, spending a lot of time studying, critically evaluating his own outcomes, his own techniques, in order to maximize efficiency and safety. So I'm going to talk about how that type of critical evaluation has informed my approach to mechanical thrombectomy. And then next is Dr. Eric Peterson, who many of you know is a graduate from this program, and he's been one of my mentors from day one, and has been a real inspiration because of how he's always thinking about how to move the field forward. And in particular, in neurointervention, we spent a lot of time developing a new approach and some new technology together. So I'll talk about that. And then finally, Dr. Bobby Stark, he is a R01 funded clinical scientist who's really inspired me to ask how we can solve our clinical questions in the lab and translate our lab findings back to the bedside. So here is where I'm really going to focus the bulk of my talk, and I'll be sharing some of the work I've done in inflammation in acute stroke. So to start off, just a brief history of stroke treatment. You know, I know for the neurosurgeons in the audience, ischemic stroke is often not considered the sexiest of diseases when compared to things like aneurysms or AVMs. But I think it's important to recognize that of all the diseases we as neurosurgeons treat, ischemic stroke is the most deadly. Every year, 15 million people suffer a stroke, 5 million die. It's the second leading cause of death worldwide, and it is the leading cause of long-term disability. It costs over $100 billion a year in the US alone. And the problem is only getting worse with our elderly population rising in what some call the gray tsunami. The stroke numbers are going to continue to increase, and the cost of stroke is going to continue to increase. So what do we have to treat this problem? Basically, only two options, and the treatment of stroke is really relatively young. The first treatment came in 1995 when the NINDS TPA trial found that giving TPA within the first 3 hours after symptom onset improved mortality from 21 to 17%. And then it took over 10 years even to expand that window to the current guidelines of 4.5 hours. 2005 was our first prospective multi-center trial using an endovascular device to try and recanalize the vessel, and that showed no benefit. They didn't give up. 2013, 3 more trials using an endovascular device, and again, they showed no benefit. And finally, in 2015, we had our first positive trial, which demonstrated significant benefit, and that was Mr. Clean, and that was followed by 4 more positive trials, which was ESCAPE, Extend IA, SWIP Prong, and REVAST. And so you may be asking, well, why did these trials fail and these were successful? And, you know, there was improved technology, but really it was about patient selection. These trials in 2013 included patients who didn't have an LVO in their endovascular arm and failed to show a benefit. So by being really thoughtful about patient selection in 2018, Dawn and Diffuse showed a benefit in patients even up to 24 hours. So what do I mean by patient selection? how do we select for the right patients to treat? So the whole basis of revascularization is the concept of ischemic penumbra. There is a infarcted core that is unsalvageable here in the red, and outside of that zone, there is the penumbra in orange, where the cerebral blood flow is reduced and physiologic function is arrested, but there isn't that irreversible cell death yet. But that zone gets gradually recruited into the infarcted core with time. And outside that zone, there's an area of oligemia with decreased blood flow, but sufficient compensation. And outside of that is the normal blood flow zone. And by selecting patients with large penumbras and small cores, gradually with these trials, we've reached a number needed to treat of 2.7 in DAWN. And that's in patients up to 24 hours after symptom onset. But how do we know who has a penumbra and who has a core? So that's really all based on imaging in the acute period, given how quickly intervention needs to be done. So we look at CTA, we identify the LVO, and we look at CT, looking for hypodensities to see how much core there is, and then we utilize CT perfusion. And CT perfusion is able to estimate core versus penumbra based on cerebral blood flow and cerebral blood volume, as well as transit time. So the core has an increased transit time where the blood takes longer to get there, but decreased blood flow and blood volume because the brain no longer needs it. And then the penumbra has that also increased transit time, but normal cerebral blood volume due to autoregulatory vasodilation. So once we decide that a patient needs thrombectomy, what does it look like? For those of you who have never seen one, this is a quick animation. There is a microwire and a microcatheter that go out through the occluded vessel, past the clot, and then we unsheath what's called a stent retriever and allow the clot to integrate into that stent retriever over the course of 5 minutes. And then some people use an aspiration catheter, other people will use a balloon to inflate and cause flow arrest, and then under aspiration or flow arrest, we pull that stent retriever out and retrieve the clot. And there are a lot of variations on this technique with catchy names like Solumbra, Adapt, Trapped. But this is what it looks like in real life. So this is identical to a case we did just 2 days ago, a right M1 occlusion. And we did one pass, pulled out this large juicy clot, and then you can see at the end that there's full revascularization of that territory. So this is the goal in every case. But the problem is, every company wants to make better endovascular technology and get a piece of that market. But the issue is that the majority of patients who present with stroke are not eligible for either TPA or thrombectomy. This was a study in stroke where they showed that only 4.9% of all patients who presented with stroke were eligible for thrombectomy. And you could say, well, we can improve that. We can improve education. So, patients know to get to the hospital faster. We can improve decision-making using things like his AI. We can streamline our approach to getting patients onto the table. But even if you can get patients in within 6 hours, that's only 17.7% of patients who are eligible for thrombectomy. So that's problem one. Problem two, even if they qualify for mechanical thrombectomy, it's not always successful. You can see here that even after 7 passes, your success rate is usually only around 70 to 80% across most studies. And then the third problem, even if you recanalize the vessel, it's not always a good outcome. You can see that there's a big distance between this line of recanalization and good outcomes. So Hermes was the pooled data from those 5 2015 RCTs. And while you can see that mechanical thrombectomy is hugely successful in improving outcomes, a good outcome of 26.5% of patients in the control to 46.5% of patients in the intervention group. What starts to get depressing after doing a lot of strokes is that still means that over 50% of patients are significantly disabled or dead after treatment. So the question is, why do some people do well and others don't? And that's shown fundamentally in this graph, which plots time and infarct volume, and this purple, represents sort of that poor outcome zone. And so you can imagine some people are here in the red, which we are calling fast progressors, and some people are here in the pink, which we call slow progressors. And it's thought that there's something biologically different, probably in the form of collaterals, that allows them to compensate for the vessel occlusion. So in the acute period, there are two approaches to improve outcomes. We can try and speed up recanalization, or in other words, try and improve patient Green's outcomes by going from point C to point B by getting faster, or we can try and slow down the disease process. In other words, try and change the slope of patient Green to somebody like patient Yellow, thereby buying us this much more time to get the patient out of the poor outcome zone. So let's start with the first target. How can we speed up recanalization? So going back to Dr. Morcos, he really emphasized studying our own outcomes and becoming a master of our practice. So that was one of the first things I had started looking at, was our own stroke outcomes. And we know that there are racial and ethnic disparities in access and treatment to healthcare. And having a strong interest in underserved population, I wondered if that was happening in thrombectomy. So we did this multi-center study looking at ethnicity. And interestingly, we found that there was no difference in recanalization times. In fact, they were actually slightly shorter in self-identified Hispanic patients, but yet they still had worse outcomes post-mechanical thrombectomy than non-Hispanic white or non-Hispanic Black patients. Similarly, we looked at BMI. We thought heavier patients are harder to transport, they're harder to get on the table, they're significantly harder to get access. But again, we found no difference in our door to recanalization times, although we found that both the underweight and the obese patients had higher mortality than the normal or overweight patients. And then we analyzed our patient anatomy. We looked at particular anatomical variations, such as a bovine arch or a more folded over arch or tortuosity in the cervical ICA, and found that these anatomical variants were associated with increased revascularization time and then consequently worse outcomes. And we found that if we used a transradial approach versus a transfemoral approach, we actually had more equivalent outcomes to our femoral cohort. And this is where Dr. Peterson really, had a lot of vision. He recognized that it's not only about improving efficiency in mechanical thrombectomy or as a bailout when a femoral approach fails, but we could improve safety across the board. And every interventionalist knows about these complications: the bad groin hematomas, the cold leg, the pseudoaneurysm, these like life-threatening retroperitoneal hematomas. And the cardiologists have already solved that problem. They've shown unequivocally in large randomized trials with over 7,000 patients that major vascular complications and even mortality is significantly lower if you use a radial versus a femoral approach. But neuro is very different from cardiac. So we set out to try and do this on the neurointerventional side and really adopt a radial first approach, and found that we could do, even the most difficult procedures, flow diversion. We did have significantly lower complication rates, both vascular access complications and overall complications. We found that we could repeat transradial access in over 95% of cases, even up to 7 times. And then we found that there are a number of unique challenges and complications with radial, but we were able to identify solutions for them, and that included developing a new catheter. So it's been really exciting and rewarding to see how this has sort of changed the way that many people practice. But just identifying our differences and outcomes and improving our technical approach really isn't enough. And what those ethnicity and BMI studies told me is that there are biological differences in response to stroke, and how could we better understand that? So this next part of my talk is really going to be about the basic science research I did looking at inflammation and stroke. So the amazing part about being a surgeon is that we have access to tissue. And in chasing these clots, we would notice a real qualitative difference in clot appearance and how difficult it was to remove. And it started to feel like a waste that we would spend all this time and energy running in the middle of the night, doing pass after pass, chasing clots only to throw them in the trash. So I started a blood and clot registry at and the first thing I wanted to do was sort of address this first target. What can we learn from the clot to improve recanalization? So many people have looked at the histology and found that red blood cell clots are associated with faster, more successful recanalization as compared to fibrin-dominant clots, which is really associated with clot origin. So we thought we'd start somewhere different and we'd start even smaller. And we decided to look at these clots under electron microscopy. So on the left is SEM and on the right is TEM. And what we notice on SEM is that some of these clots have these really thin fibrin strands and other of them have these really thick strands. And then on TEM, what we saw were these multinucleated cells with these pseudopodocytes, which we identified as neutrophils. And what we realized is that what we were probably seeing is something called neutrophil extracellular traps, or NETs. And NETs is a great name because they are exactly what they sound like. These are large extracellular webs that are made up of proteins on a scaffold of decondensed chromatin. And they were actually first discovered in sepsis as a mechanism for neutralizing and trapping bacteria, and then subsequently also were found to stimulate pro-inflammatory response. And so they've been shown to be present in stroke thrombi. And interestingly, you can imagine as these webs are growing that they are probably contributing to a more dense and adherent clot. So one study found that higher net concentration is associated with longer recanalization times as well as increased number of passes. And the process by which they are released was initially termed netosis because it was thought to be similar but distinct from apoptosis, where cell death occurs, except in this case, the neutrophil nucleus disassembles and the DNA and the neutrophil granules are all released. They've also, however, found a separate pathway, a non-lytic method, where neutrophils can exude primarily mitochondrial DNA and the cell doesn't necessarily have to die. So we wanted to know what activates netosis in stroke thrombi, and this is work that was supported by the Dempsey grant that I received and was published in Frontiers in Pharmacology. And I started looking at this question by actually linking up with these two guys here. So this is Dr. Pablo Vaccari and Dr. Bob Keane, who are scientists in the Miami project who have spent a very long time studying something known as the inflammasome. So inflammasomes are these cytoplasmic multi-protein complexes that are part of the innate immune system, and they contain multiple parts. There is a sensor molecule, which is known as NLRP1, or the most studied one in stroke is NLRP3 and AIM2, and they sense when a molecule is in danger, when a cell is in danger, and they communicate with the adaptor protein, or ASC, which also contains a caspase recruitment domain, which connects to caspases 1 or 5 or 11. And together, the inflammasome regulates the activation of these caspases, which then induce inflammation by cleaving IL-1 beta and IL-18 to their active forms. So previously, Dr. Vaccari and Dr. Keane had identified that caspase 1, ASC, and IL-18, the inflammasome proteins, were elevated in post-stroke patients. But we also know that inflammasome inflammation can induce netosis. In mouse models, they've found that microscopic cholesterol crystals can actually initiate inflammation by activating the inflammasome in a macrophage, which, again, going through that pathway, activates the caspase, activates IL-1 beta, IL-18, which then can actually activate the inflammasome in the neutrophil to activate gasdermin and then induce netosis from the neutrophil. So we wanted to know, well, is that happening in these human stroke thrombi? So we co-localize the NET proteins which is citrullinated H3, histone 3, with the inflammasome proteins, caspase-1 and ASC, and found that they did, in fact, co-localize in the thrombi in the extracellular space. So we thought, well, if the inflammasomes are playing a major role in the thrombi, are they quantitatively elevated? So we compared the thrombi in 24 patients who underwent successful mechanical thrombectomy with the peripheral plasma in those patients taken at the time of thrombectomy, as well as healthy controls. And again, we looked at those same inflammasome proteins, ASC, caspase-1, IL-1 beta, and IL-18, and found that ASC, caspase-1, and IL-1 beta were significantly elevated in the clot as compared to the plasma and control. IL-18 was actually lower in the clot than plasma, which may be because the precursor IL-18 is actually constitutively expressed in whole blood cells, and our immunoassay didn't differentiate between the precursor form and the active form. So then we performed a linear regression model, and we thought, if these inflammasome proteins in the thrombi are significantly elevated, are they actually correlating with clinical outcomes? And we found that the IL-1 beta did in fact predict higher number of passes. ASC, caspase-1, and IL-18 also were associated with increased last known time to recanalization. And then we also found that IL-1 beta greater than the median was associated with worse outcomes overall. So to summarize, inflammasomes are activated in stroke thrombi, and they are present in nets. What does that mean? That means that inhibiting inflammasome activation may actually decrease clot formation and propagation by decreasing net formation. So maybe, we are addressing that first target of speeding up recanalization by inhibiting this inflammasome-induced netosis. Second conclusion from this study was that elevated IL-1 beta contributes to worse outcomes in patients after stroke. What does that mean? Well, maybe inhibiting inflammasome and IL-1 beta activation early on in the acute stroke period may actually decrease inflammatory damage. So maybe, we were starting to get at this second question of how we can actually slow down the disease process. So the question is, what might the mechanism of that be? So there is this theory of not only an ischemic penumbra, but something known as a inflammatory penumbra. Essentially, there is a zone of brain tissue beyond the ischemic tissue that gets recruited into the core due to inflammatory damage, because we know that under normal conditions, immune responses in the brain are highly regulated, and other than the microglia, other immune cells are really absent from the parenchyma. However, in ischemic stroke, you get a strong inflammatory response and subsequent infiltration of these peripheral leukocytes, which can cause additional damage beyond just the ischemic damage. And this hypothesis is particularly salient and has led to a number of clinical trials because these anti-inflammatory drugs in animal models have been shown to be neuroprotective. Things like IL-1 receptor antagonists, minocycline, which is an antibiotic with strong anti-inflammatory properties, anti-ICAM1, and anti-VCAM1 drugs have all been tested. However, they've all been negative. And so, I think similar to those early mechanical thrombectomy trials, perhaps we're just not giving them to the right patients at the right time or in the right way. And we're certainly not testing them in combination with mechanical thrombectomy yet, even though we know in animal models that the transient MC occlusion and permanent MC occlusion brains behave really differently. So we wanted to know, what is the spatial temporal profile of inflammation during acute ischemic stroke, large vessel acute ischemic stroke? And this was the work that was supported by my R25 and that we published in Journal of Cerebral Blood Flow and Metabolism. So again, we started with the idea that there are thrombi which have nets, which are activated by inflammasomes. And we know that inflammasomes activate IL-1 beta and that there are high concentrations of IL-1 beta in thrombi. Well, we know that IL-1 beta is a major mediator of that inflammatory response. And so it can have a number of downstream effects. It can increase pro-inflammatory cytokines, it can increase angiogenesis, it can increase cell migration, it can increase extracellular matrix degradation and decrease its synthesis. It can decrease myofibroblast differentiation. So, in order to start to understand the profile of this, we thought we would look at some of the downstream effects of IL-1 beta, understanding that IL-1 beta is upregulated in thrombi. So the first thing, and one of the most salient, is that IL-1 beta stimulates induction of pro-inflammatory cytokines. And these pro-inflammatory cytokines have been looked at in both animal models and humans. There have been small studies of plasma and CSF levels of these cytokines in non-recanalized patients. But the time course in which they get these samples ends up being, post-stroke, 1 day, 3 days, 7 days, generally because they don't have access to these patients in that really acute period. And then in animal models, they've looked at things like IL-16F and IL-1 beta, and have really shown that these cytokines start to skyrocket within the first 6 hours. And they found that in particular, IL-16F and IL-1 beta are associated with infarct volume and outcomes. But really, no one has looked at it in clot, and no one has really differentiated where where these pro-inflammatory cytokines are coming from. So, we thought that we would try and spatially differentiate where these elevated pro-inflammatory cytokines are. So we looked at 40 clots, or patients who underwent mechanical thrombectomy. We collected peripheral blood from their femoral or radial sheath, and then cerebral plasma from a aspiration catheter that was parked proximal to the clot at the time of thrombectomy. And we found that the pro-inflammatory cytokines IL-2, IL-16, IL-6, and IL-1 beta were all upregulated in the clot as compared to the peripheral and cerebral plasma. So IL-1 beta we've talked about, but IL-1 beta stimulates IL-6 transcription, and both IL-1 beta and IL-6 are procoagulants. And this is important because even if you're able to get the clot out in whole, we know that actually IL-6 can mediate thrombus formation distal in the cerebral microvasculature. So you may be getting more thromboemboli just from the presence of IL-6 from that initial clot. IL-6, we also know, induces acute phase reactants, which can simulate a large systemic inflammatory response. And I will talk a little bit more about that a little later. And then IL-2 and IL-16 are really a link between the innate and the adaptive immune system, and they can upregulate a Th1 response. IL-2 is known to induce T cell proliferation, and IL-16 really regulates T cell growth and induces cell migration. The other thing to notice here is that there are a number of cytokines that are actually higher in the plasma than they are in the clot, predominantly from the Th17 response, and that includes things like IL-12, IL-17, and interferon gamma, which again can mean that there may be a differential response between the clot and the plasma. And then I think the last thing that we found was interesting was that there really was no difference between the peripheral and cerebral plasma, and that may be because we weren't really getting the plasma that was actually distal to the clot, and everything else was sort of just mixing together and really about the same. We also know that when pro-inflammatory cytokines are activated, anti-inflammatory cytokines are actually also activated as a check on the system. And so anti-inflammatory cytokines have also been found to play a major role in the inflammatory response after stroke. In particular, IL-10 levels in plasma have been found to be reduced post-stroke, and that the lower the IL-10 level, the worse the outcomes. And in animal models, administration of IL-10 positive B cells actually decreases infarct volume. So we wanted to look at IL-4, IL-13, and IL-10 because we know that the microglia differentiate into M2 subtypes with the help of IL-4 and IL-13, and then they produce IL-10, which actually inhibits the pro-inflammatory cytokines that come from the M1 microglia subtype. So we looked at IL-4, IL-10, and IL-13 again in clot, peripheral plasma, and cerebral plasma, and found that both IL-4 and IL-13 are significantly elevated in the clot as compared to the plasma. So this may be a feedback mechanism for that pro-inflammatory response and offers, additional viable targets to further study. So how do these pro and anti-inflammatory cytokines actually get into the brain? IL-1 induces production of angiogenic factors. And, you may be thinking, well, angiogenesis is good in stroke. Higher levels of VEGF after stroke can activate angiogenesis that supports tissue repair in the penumbra by growing more collaterals. But really, that's in the delayed stroke period. Excessive VEGF levels early on after infarct seems to adversely affect stroke recovery by increasing the blood-brain barrier breakdown, thus increasing inflammatory cells, edema, and hemorrhage. So we wanted to know, are thrombi a potential source of angiogenic factors? So we looked at the full family of VEGF factors, VEGF-A, C, D, BFGF, and PIGF. And we found that VEGF-A, C, and BFGF were significantly elevated in the clot as compared to the peripheral and cerebral plasma, whereas PIGF and VEGF-D were significantly lower in the clot. And I thought this was pretty interesting because VEGF-C and D are quite similar in function, but clearly differentially expressed in the clot. But these two cytokines have actually been studied in coronary artery disease, and it's been shown that low serum VEGF-C, like we see here, and high serum VEGF-D are both associated with increased mortality in patients with coronary artery disease. So it may be that actually VEGF-C and D together are good markers for severity of vascular disease. So the other thing we looked at here were Tie2 and FLT1. Tie2 is a angiopoietin receptor, and FLT1 is a VEGF receptor. And because they're receptors, it's not surprising that they're significantly lower in the clot as compared to the plasma. But I thought the FLT1 finding was particularly interesting because it's the only factor where we identified a higher concentration of factor in the cerebral plasma as compared to the peripheral plasma. So this may actually help us in trying to differentiate stroke from other non-specific inflammatory states for a biomarker for stroke, for example. And taken together, all of these are also additional potential targets that require further study and need to be compared with healthy controls in order to see if they can be used as markers of disease. So hand in hand with blood-brain barrier breakdown is the recruitment of leukocytes. We know that IL-1 induces cell migration by signaling increased expression of cell adhesion molecules on endothelial cells to recruit leukocytes. So if you recall the slide of the clinical trials, ICAM1 and VCAM1 have both been major targets of neuroprotective agents, and that's because ICAM1 is one of the best known molecules involved in leukocyte adhesion, and IL-1 beta stimulates the increased expression of ICAM1 by endothelial cells, and this is thought to be important in driving that leukocyte infiltration from the blood to the brain parenchyma. And elevated ICAM1 has also been shown to be associated with worse outcomes, but it hasn't really been differentiated when that elevation of ICAM1 really occurs. So we wanted to look at the temporal profile of these molecules in relation to mechanical thrombectomy. We also wanted to study the temporal profile of acute phase reactants. So, like I mentioned before, inflammasomes activate IL-1 beta, which activates IL-6, which tells the liver to produce all those bad acute phase reactants like fibrinogen and CRP, SAA, which then acts on the endothelial cells to actually aggravate atherothrombosis. And we know also that CRP is also associated with worse post-stroke outcomes. But again, we really don't know the temporal profile of that increase. So we compared clot to peripheral and cerebral plasma, and we looked at it pre-thrombectomy. So again, we drew peripheral plasma from a femoral sheath, cerebral plasma in the ICA or MCA from a distal aspiration catheter. And then we looked at distal cerebral plasma, where we actually took the microcatheter out past the clot and was able to draw a blood sample past the clot in the distal cerebral microvasculature. And then we looked at blood immediately post-thrombectomy from, again, a aspiration or a guide catheter, and then peripheral plasma from the sheath. And then we took a peripheral sample 24 hours out. And so looking at the acute phase reactants, CRP and SAA, we found that they were significantly lower in the clot, and that CRP seemed to uptrend and be highest at that immediately post-thrombectomy peripheral blood and seemed to decrease after 24 hours. SAA seemed to be elevated both pre and post-thrombectomy, and again, seemed to go down after 24 hours. ICAM1 and VCAM1, those adhesion molecules, seem to be elevated in the plasma, but really, again, they seem to trend to be highest in that immediate post-thrombectomy peripheral plasma, and then downtrend at 24 hours. And, I think that this may be the key to why some of those clinical trials were actually failed, is they were giving these anti-ICAM or VCAM1 inhibitors 1 to 5 days after stroke, where perhaps already the levels of ICAM1 VCAM are decreased, and they were finding that there were worse outcomes because patients were having higher rates of infection, and that may be because you're not really affecting the post-stroke inflammatory profile, and they're really having non-targeted systemic effects from it instead. So to summarize, pro-inflammatory cytokines, IL-6, IL-16, IL-2, IL-1 beta, and anti-inflammatory cytokines, IL-4 and IL-13, are present in high concentrations in these large vessel occlusion thrombi. These thrombi also have high concentrations of those angiogenic factors, VEGF-A, C, and BFGF, whereas the peripheral plasma has high concentrations of VEGF-D and high cerebral plasma concentrations of FLT1. The acute phase reactants, CRP and SAA, as well as the endothelial adhesion molecules, ICAM1 and VCAM1, trend towards being greatest in that immediate post-thrombectomy peripheral plasma and seem to decrease after 24 hours. And why is this all important? Really identifying the spatial temporal profile of this inflammatory reaction after stroke is really critical for understanding what the best time and the best method for intervening in this patient. Oops. So I hope I've convinced you that at least there remains a lot of work to be done in stroke treatment, and these results have spurred a lot of additional questions and projects for me. So the first goal, speeding up recanalization. Certainly we can always improve our technique. We can always improve our technology. We can streamline the process, but also the next step is to inhibit that inflammasome mediated netosis and see if we can actually decrease clot formation and eventually translate that to improving recanalization success. I think this work is also important for identifying a biomarker, and it's been really exciting to collaborate with Dr. Levitt and Dr. Walker and the team here, who are also working on identifying a biomarker for stroke. And they're using really unique patient populations and innovative methods to do that. So I think together we'll be able to have some really interesting findings. And for the second goal, to slow down the disease process, I think it's really important to continue to map that spatial temporal profile of the inflammatory cascade. We need to expand past this 24-hour time period, get sample from non-reperfused patients. This is one of the main limitations of my study, is that because we were using clot and peripheral and cerebral plasma, we only had successful thrombectomy patients. We were not able to get clot from the unsuccessful thrombectomy patients. But by doing this mapping, we'll be able to identify targets for patients that are not eligible for a TP or thrombectomy and who have unsuccessful thrombectomies. And I think it's also important for identifying the right patients with the right time period for treatment, and that I suspect will actually have to be before thrombectomy, or at least during thrombectomy, given what we're seeing in these acute rise of pro-inflammatory cytokines during the acute stroke period. And then I also think that understanding this biology is going to be important in developing drugs that could be preventative. For example, by comparing the inflammatory profile of the thrombi to things like carotid plaque, we'll find additional ways to stabilize the plaque, prevent stenotic progression, and prevent thromboembolic events as well. So lots of work to be done, but I have a lot of people to thank for the help with the work that has already been done. These guys here who basically taught a neuroscience major how to do molecular biology and immunohistochemistry and electron microscopy, as well as the clinical team for all their advice and collaboration, and my funding sources for getting this research done. And I also want to thank the team here, first and foremost, Dr. Ellenbogen, for allowing me to be a part of this wonderful department this year, and for your vision for the endovascular fellowship, as well as all of the cerebrovascular faculty in the neurosurgery and IR department, who have already become great mentors for me. Dr. Kim, Dr. Levitt, Dr. Shaker, Dr. Walker, Dr. Godkin, Dr. Hallam. I've learned so many things from you guys already, and you guys have so many exciting projects and insights that have been really inspiring for me. And of course, there are Novus and Microvention for helping me put food on the table, particularly for these guys here, and this little man who teaches me the most every day. So thank you all for listening.